So good evening, everyone. I'm Dr. Amaran on behalf of National Spice Route, part of AFPA. So as our national classroom session, which will happen monthly once. This time, Tamil Nadu State Chapter Spice Route has taken this session. I would like to introduce Dr. Shweta, who's the PG coordinator of State Chapter of Tamil Nadu Spice Route. And I would like to welcome all and have a great time. Over to you, Shweta.
Okay. So, hi. Hello. Hi. So, I'm Shweta, Dr. Shweta, currently working as an SR in CMC. So, without further delay, let's start our session. Today's our session is from Tamil Nadu, from Christian Fellowship Hospital. So, Dr. ALEENA is my dear junior. Currently, third year junior from Christian Fellowship Hospital, Oddanchatram. And we have two moderators today. And the moderator is Dr. Rajkumar Ramasamy, our dear mentor. So, who is currently is in charge of KC Petti Primary Health Center. If I wanted to introduce about him, he is the pioneer who has started family medicine in India initially as a D&B course. So it was such an honor to learn from him and to learn what family medicine is. And I'm really glad that the postgraduates and people who have attended today will also get to learn that from him. Our another moderator is Dr. Pranita ma'am. So, ma'am is HOD of family medicine from Meenakshi Mission, Madurai. She's currently the AFPA Tamil Nadu lead. So I would really like Rajkumar sir and ma'am to moderate the session. And I think without further ado, I think let's start. ALEENA.
Okay, ma'am. I will share my screen.
Yes, da. Yes, da.
Is it visible to all, ma'am?
Yes, it's visible.
Okay, sir. Shall we start, sir?
Yeah, please do.
This is a case of Miss Mahima, 10-year-old girl from Siruvatukada, an interior tribal village located in Lower Kodaikanal Hills, who presented to Kesipatti PHC with her mother, who is a reliable informant, with chief complaints of migratory ankle joint pain and swelling since 2 weeks, fever on and off since 2 weeks. History of present illness. Child was apparently well 2 weeks back. Then she developed pain and swelling of right ankle joint, which was acute in onset, gradually progressive, associated with difficulty in walking, and the symptoms subsided within 2 days with paracetamol. 1 week later, she developed pain and swelling of left ankle joint also. During both episodes, the child had high-grade fever not associated with chills or rigor, but subsided with antipyretics. There is no history of trauma or fall, no history of similar joint pain or swelling in the past, no history of small joint pain or early morning stiffness, no history of recurrent sore throat, no complaint of chest pain, palpitation, or breathlessness, no complaint of involuntary movements, emotional lability, or change in handwriting, or no history of any skin lesions or nodules. Past history, no similar complaints in the past, no known congenital or rheumatic heart disease, or no comorbidities. Family history, No similar complaints in the family members. No history of rheumatic fever or heart disease in family members. Coming to the 3-stage assessment, individual factor, the mother of child initially thought that child might had some trauma while playing and hence the ankle was swollen and painful. When later it migrates to the another ankle, mother was scared and felt something abnormal and brought the child to clinic. Her expectation is wants to get better of this condition. Coming to the contextual factor of the child belongs to lower socioeconomic class according to modified Kupusamy classification. She lives in an interior tribal village named Siruvatakada, which is around 10 km interior to the main road, and her home locates 1 to 2 km inside that village, where transport and healthcare facilities are yet difficult to access. She lives in a kacha house with poor ventilation and overcrowding. Lives with her father, mother, siblings, and grandmother. Both her parents are daily wage manual workers, and father is an irresponsible person who used to drink alcohol whenever he is paid. Developmental history, no history of delay in achieving milestones. Child is now studying in 5th standard with good scholastic performance. Immunization history, child is immunized till 10 years. Coming to the summary, this is a case of 10-year-old girl presented with migratory large joint pain and swelling with fever during these episodes since last 2 weeks without any complaint of chest pain, palpitation, dyspnea on exertion or abnormal movements. From the history, the system involved is musculoskeletal system, and my probable differential diagnosis include acute rheumatic fever, septic arthritis or reactive arthritis, viral arthritis or juvenile idiopathic arthritis. Coming to the general physical examination, child was conscious, cooperative and oriented, afebrile at the time of presentation, not sick looking, no pallor, icterus, cyanosis, clubbing or lymphadenopathy, no skin rashes or subcutaneous nodules noted. Vitals, BP was around 120/64 millimeters of mercury measured over left upper limb in sitting position. Pulse rate of 105 beats per minute, regular, normal in volume and character. Temperature of 96.8 degree Fahrenheit. Respiratory rate of 20 per minute and saturation of 99% at room air. Anthropometry, her weight is around 28 kg with a height of 130 centimeter, which comes BMI around 16.6 kilogram per meter square, which lies in between 0 to -1 set score based on WHO data. Coming to the systemic examination, musculoskeletal system, left ankle joint inspection, swelling present over medial malleolus, no deformity, muscle wasting or skin changes noted. Palpation, no redness or warmth, no tenderness present over medial malleolus. Movements, dorsiflexion and plantar flexion was restricted and painful. Right ankle joint was normal at the time of examination and no other joint swelling or deformity noted. Cardiovascular system examination, inspection, chest wall was symmetrical, no deformity, apical impulse not seen, no precordial bulge, visible pulsation, sinuses or scars noted, JVP was not elevated. Palpation, inspectory findings are confirmed, apex impulse felt at left to fifth intercostal space medial to mid-clavicular line, no thrill or parasternal heave noted. Auscultation, first and second heart sound heard normally over all regions, no murmurs noted. Other system examination were within normal limit. Coming to respiratory system, chest movements were symmetrical, trachea was central with vesicular breath sounds and no added sounds. Abdomen was soft, non-tender with no hepatosplenomegaly. Central nervous system, child was conscious oriented with no involuntary movements, tone, power and reflexes were normal. So coming to the summary, this is the case of 10-year-old girl from a lower socioeconomic background presented with migratory large joint arthritis and fever with no evidence of carditis or chorea. This clinical features suggest most probably the case of acute rheumatic fever without carditis. Considering other differentials include reactive, that is post-streptococcal arthritis, septic arthritis, viral arthritis or juvenile idiopathic arthritis, also systemic lupus erythematosus. Should I continue, sir?
Yes, please do.
Okay. When the child came to our health center, initially our health workers used to do assessment of the child. The health worker will take a detailed history of the child. Also, they will record the vitals, and also they will note before the child reaches the doctor's cabin, they will give a clear contextual factor about the child. As the child is from a far away interior village and mother has taken child all the way to the clinic, which is around 20 kilometers away in the hills, since something serious wrong with the child. So this health worker knows the child's family and their socio-economic status better, since the health worker is from the same community. Also, health worker has done a ESR since there was the history of migratory joint pain. Coming to the investigations we did, ESR showed 90 was elevated, that is 90 millimeter in the first hour, and anti-streptomycin O titer showed more than 400 international units per ml. And an ECG done showed a PR interval which comes in a borderline range, that is around 180 milliseconds. So the management, the diagnosis we made according to modified Jones criteria. Our locality belongs to moderate to high risk population, and since there is a major criteria as arthritis and the two minor criteria as fever and raised ESR, diagnosis was made as acute rheumatic fever without carditis. So the management we did in our clinic is initially we explained the disease process to mother and child. That is the very core need of the treatment. That is, the child and their family should know about the disease and the process of the disease. So we explained them like this is caused by a bacteria which initially causes throat infection. Sometimes if the throat infection is not treated properly, the child's immune system becomes overactive to the toxin, and it mistakenly attacks the part of body, especially heart, joints, skin and brain. So the most serious part affected is the heart valve. If not treated properly, it will damage the valve permanently and cause long-term heart diseases. Along with the information about the disease, we also inform the child and her mother that we can win over this disease with proper and regular treatment. Then we explained about the treatment modality. The current illness can be treated with the medicines which reduce inflammation and control symptoms. But the most important part is the need of monthly injection. That is, it is very important to prevent the disease from coming back and to protect the heart. If the child feels completely normal also, the injection must be continued till 21 years of age, and the missing of this doses will increase the heart damage risk also, we were clearly explained. And also we had addressed the fear of the mother and also given reassure with the proper treatment and regular follow-up. A child can live a normal healthy life like most of the other children. We gave an injection benzoyl penicillin, that's Penidure, 12 lakhs intramuscular injection, and then started on NSAIDs, diclofenac 50 mg half BD for 1 week, and child showed a dramatic improvement with the NSAIDs. Then for our further management, we added her on our recall system. That is, she belongs to our covering area village. So we added her name to the village follow-up file, and we were planning a village visit to that village after 1 week. So we decided to do an home visit also during that time. These are the images of the village visits and the interior villages and the living standard of most of the people who were coming to our PHC. These are our village visit photos. During the village visit to Siruvattukada, we visited Mahima's house also. This blue plastic sheet hatched house is Mahima's house, and it clearly signifies the poor living standard from which the child is coming. So other aspect also we took care was the anemia prevention. That is, in most of this low socioeconomic community, the most prevalent disease is anemia, which is not a lesser one till now. So the anemia prevention also plays a very important role in management of this disease, since it can aggravate the congestive cardiac failure and other complications. And also we inform the child and the mother that have to seek early help in case of any fever with sore throat, any effort intolerance, breathlessness, or swelling of legs. So next major aspect as a family physician, we have to take care is the compliance. For ensuring compliance, we used to explain clearly about the disease process. The clear understanding is needed for the patient and the attender to be compliant on the treatment. And also, we used to put them in a recall system where if the patient relapses or misses the doses, health worker will notify them and call them and used to inform them as they have to return to clinic for the injection. Also for children, we used to do, for motivating, we used to give a reward system. That is, if the child is regular for the injection for 6 months, we used to give a prize to the child, which motivate the child for regular injection. Also, we can advocate in the school for allowing permission for monthly injections and motivate the child to go for injection. This is the photo of Mahima with reddish eyes and a gloomy face, which shows after a painful penicillin injection. With the initial bit hesitancy, but now with a clear understanding about the condition, Mahima is continuing her monthly injections now. Thank you all.
ALEENA, it was a very good presentation.
Ma'am, am I audible, ma'am?
Yeah, your voice is heard. I think mine is echoing. I think now it's not echoing, right?
Now it's fine, ma'am.
Okay, thank you very much, Dr. ALEENA, for that very good presentation of a child with rheumatic fever. If it's okay with you, Dr. Pranita, I'd just like to share a few slides to emphasize some of what Dr. Anila said. So I'd just like to share my slides.
Okay, sir.
Hey, thank you very much for giving me this opportunity to be a moderator in this. I'd like to say that I'm a family physician working in a remote area, and I'm very proud to be one. And for those of you who have just started your residency, it's really good to be having a chance to talk to you. I'd just like to say that what you have chosen as a field is not just the most beautiful specialty in India, but that which India needs most. And perhaps some of the things about this case history will help you to realize that. Because as far as rheumatic fever and rheumatic heart disease are concerned, India has one of the heaviest burdens in the world. And the ability to prevent this burden is not just with pediatricians and cardiologists. Actually, it's far more important, the responsibility of family physicians like you and me. And so it's a good condition to talk about. So regarding rheumatic fever, I think most of you know it's caused by group A beta hemolytic streptococcus. And this streptococcus loves overcrowded conditions like in Mahima's home. And some of the overcrowded conditions are those like houses with poor ventilations in slums, and also very much in the rural schools and town schools that we often have, with children sleeping like this. But it's also a condition where people have poor access to water, and we'll talk about that because of skin diseases, which probably do have an important cause for rheumatic fever in India. And it's, of course, more common in rural and remote villages. So what should we as family physicians do to prevent rheumatic fever? And one of the first things is to treat streptococcal sore throats properly. So when a child comes with streptococcal sore throats, how do you diagnose it for a start? Because sore throats are common and streptococcal infections are only about 30% of the cause. The idea that was often proposed by many people is that in India we should treat every person with a sore throat with an antibiotic. But I think as family physicians, we can be smarter than that. Because India carries the worst burden of antibiotic resistance, and we can't really end up giving treatment for every person with a sore throat. So what are the things that are there to help? Many of you will already know the center criteria, which gives 4 particular physical signs that suggest that a streptococcal infection is more likely than a viral infection. And of these criteria, the first 2, the exudates and follicles on the tonsils, and the lack of other respiratory symptoms like cough and runny nose, are the 2 most important parts of the center criteria. The other ones include enlarged lymph nodes and a fever that is high grade. Now, many doctors say that the center criteria for detecting streptococcal sore throats are not accurate because they're not specific to streptococci. But what I'd like to say is that as a family physician, when you look at the negative predictive value of the center criteria, what we want to do is not miss streptococcal sore throats. It's not a point of diagnosing it, but we don't want to miss it. So if you say that there are 2 or more of these criteria that are positive, then I will use an antibiotic to treat it. And in that way, the sensitivity of screening for streptococcal sore throat is around 90% with 2 or more criteria being positive. So you're not going to miss streptococcal sore throats. There are rapid antigen tests being developed to detect streptococcal sore throats. And that may be a useful way of detecting this more clearly in the future, but it's not widely available in India yet. So let's also look at streptococcal skin infections. As you know, impetigo is also caused by Streptococcus group A. Many people think that impetigo only causes poor streptococcal glomerulonephritis. But in many areas, especially in the indigenous communities in Australia, it's being shown that impetigo associated with group A beta hemolytic strep is a cause of rheumatic fever as well. And if that's the case, we as family physicians need to take impetigo seriously and eradicate streptococcus as a cause of it. Of course, sometimes it's caused by Staph aureus, but we're really after the streptococcus, which cause rheumatic fever and streptococcal glomerulonephritis. And as many of you know, impetigo is often associated with scabies. So treating these skin infections properly is one way of preventing acute rheumatic fever. And what's the best option? The best option is benzothine penicillin single dose. It is the beta hemolytic strep are always sensitive to penicillin. And despite the rise in antibiotic resistance, they're still sensitive to it. And this single dose will effectively get rid of beta hemolytic strep in both the throat and the skin. If you can't give it, there are other options like phenoxymethyl penicillin or amoxicillin or azithromycin or cefalexin, but really they are second choices because the compliance with these drugs is very poor, and resistance to azithromycin is about 30% for beta hemolytic strep. So as Anila was pointing out, we need to get this right. We need to make sure that we diagnose acute rheumatic fever to prevent serious rheumatic heart disease. And we have to get the diagnosis right because overdiagnosis is going to cause a terrible burden for the family with long-term penicillin prophylaxis. And underdiagnosis that results in repeated infections that cause rheumatic carditis is a serious problem. So what do we need to look at? You see, the problem is that for over 50 years, we've relied on the Jones criteria to diagnose it. There is no particular test that tests for rheumatic carditis. And when you look at the criteria, make sure you look at the Jones criteria for moderate and high risk population, because almost the whole of India is a moderate to high risk population. And the key things that have changed in the last few years is that monoarthritis is included as a major factor, whereas previously it was not. And so is a history of polyarthralgia included as a major risk factor. The other thing you'll notice is that fever is only 38 degrees. But more than that, for us as family physicians, what is important is that if the mother or father says that the child had high-grade fever, then that itself is significant. The history itself of fever becomes a minor criteria. And in Mahima's case, that was what the mother suggested. The ESR is really important because it's less than anything more than 30 is important, whereas previously the level of 60 was taken as important. And ESR is important because it's more sensitive in rheumatic fever than the CRP, and we'll come to that. So regarding carditis, how do we diagnose this? It's sometimes very difficult because it's a clinical sign that's very important. And it's particularly with children like Mahima, we are in the periphery and we don't have easy access to echocardiograms. Pay attention to tachycardia when the fever settles. If the tachycardia is still high, disproportionate to the fever, or if you can get a chance of getting a sleeping pulse rate, then that is a strong indication of carditis. Unfortunately, it's not one of the major or minor criteria, but as family physicians, if you have a child in a peripheral clinic and they only have polyarthritis and a history of fever, and you can't do an ESR or ASOT in the peripheral clinic, then a tachycardia itself should really warn you that this really is rheumatic fever. So what I'm saying is that as family physicians, when we seeing patients in less than ideal circumstances, be willing to look at the criteria and alter them when you need to, and use your common sense. New heart murmurs are obviously crucial. And I'd like to say that unfortunately, the ability to use a stethoscope is becoming increasingly poor in new medical graduates. It's really important that you keep up your clinical skills, because as family physicians, we are the frontline doctors and we are going to be working in the field where clinical skills are really important. Use a stethoscope. Please do this. Listen to the skin. Don't do that. Unfortunately, in India, where I often see doctors listening over a jacket or a sweater, and it's quite ridiculous, and it should not happen. So if you are a family physician and you want to practice good family medicine, then you need good clinical skills. Please listen to the chest on the skin, not over clothes. An echocardiogram is suggested as you do that in acute rheumatic fever if there were no signs of carditis. But of course, in rural areas, that's often not available. And in my view, it's not essential to do it during the acute episode of rheumatic fever if there were no clinical signs of carditis. You can wait, and I'll tell you why. The modified Jones criteria also uses monoarthritis as a criteria, which didn't exist before. So when a child comes with monoarthritis and fever, is it rheumatic fever or is it septic arthritis? Now that's a really crucial question. And when you're out in the field and you're in a primary health center or a peripheral clinic, it's often difficult to differentiate the two. What I do sometimes when it's hard is to give a dose of NSAID. I would go as far as giving injectable ketorolac, or if not, a dose of ibuprofen 10 milligrams per kilogram, and I'll watch and wait for 2 hours. Usually, if it's rheumatic fever, there's a dramatic response. And in septic arthritis, there won't be a good response. There will still be significant restriction in range of movements. So this is another adaptation we sometimes have to do as family physicians in the periphery, using common sense, looking at protocols, and be willing to modify them when contextual factors like what sometimes happen in primary healthcare are overwhelming. These nodules that Dr. ALEENA was suggesting are very characteristics if they do occur. They're usually painless. They can be sometimes painful. And erythema marginatum is a rare complication of rheumatic fever. It usually occurs like urticaria, but unlike urticaria, it's not itchy or painful. And it's very difficult to see in brown skin anyway. The ECG is important, and if at all possible, you should get an ECG as at the time of the acute diagnosis because it gives an important minor criteria. But remember that the PR interval, which is measured from the beginning of the P wave to the S wave, should be less than one large square. But in children, the normal range between the age of 3 and 11, which is Mahima's age, the normal is 0.16 seconds. So in children, the PR interval, that is a reference point, is less than what it is in an adult point, and will give you an important minor criteria to diagnose rheumatic fever. Korea, if we can find it, and if if this talk is recorded, have a look at these links. I'll try and get one of those if I can. I think I'll miss that because I'm scared of losing my shared screen. But if you look at that, Korea, when you can diagnose it, is a criteria by itself is enough to diagnose rheumatic fever. You don't need any of the other major criteria or minor criteria. I was telling you about the ESR. This is something that as family physicians, we should be able to do in our clinic. It's very easy to do. All you need is the correct tube, which is usually the black colored tube. And then you have this pipette, you just push the pipette into the tube and the column of blood goes up. And after 1 hour, you can read the ESR depending on the column going down. This is something we use quite a lot even in our peripheral clinics because it's easy to do and health workers can do it very reliably. And as I said, it's more sensitive than the CRP. So if you're doing peripheral clinics and family medicine and you're seeing patients, please make sure you can do the ESR in the clinic yourself. The ASOT levels are often quoted as important because in the new Jones criteria, it's not enough to just have 2 major criteria or 1 major and 2 minor. You have to show that there's been a streptococcal infection. Now that's sometimes difficult, particularly because in the poorer communities in India, streptococcal infections are common and ASOT levels are naturally high. So I would use a cutoff of 400 for a positive ASOT if you're working with poorer communities where streptococcus infections are much more common. Echocardiography should always be done in children who have rheumatic fever, whether or not they have signs of carditis. Because if it shows there was a sign of carditis, then it means that the duration of penicillin prophylaxis becomes longer and different to if there was no carditis. But it's sometimes difficult in situations like where Mahima came from. Getting access to echocardiography can be difficult. I don't feel there's any need for us to do an echocardiogram at the time of diagnosis, whether they have no carditis clinically or if they have carditis without heart failure. Obviously, if they have heart failure, you're going to try and do your best to refer this child, and they'll have an echocardiogram there anyway. It can be done as an outpatient, and in family medicine, I don't think there's any real need to do it if there is no heart failure present. So when this child comes to your clinic, do you refer this child or not? Now, that may be difficult. It depends on the contextual and individual factors and depends where you are and your own comfort zone in dealing with this. Obviously, if you're unsure of the diagnosis and you're worried about septic arthritis, usually if it's polyarthritis, it's not likely to be septic, though occasionally it can. If it's monoarthritis and you're not sure, then you need to refer. Or if there's a significant other differential diagnosis, the child being systemically ill, so there could be other causes of the fever. But if there's no carditis on clinical grounds and you're sure of the diagnosis, then I don't feel a referral is essential, though many books say they should be referred to a pediatrician. Depending on the home situation and location, I feel it can be managed as an outpatient. And we as family physicians should be able to get access to an echocardiogram and arrange this as an outpatient. If you have carditis without heart failure, consider a local admission or home circumstances. Consider the home circumstances and possibly do a daily review. An echocardiogram can be done later. I feel the indications for referral are really if a child has rheumatic fever, has carditis with acute heart failure or severe chorea, then they should be referred to a hospital. Feel free to interrupt if you have any questions or comments on this. So what's the treatment? The treatment is still benzathine penicillin. It's the best treatment to make sure that if there are any residual streptococci present in the throat of someone with acute rheumatic fever, then you get rid of it. Azithromycin is a poor second choice, as I said, and it should be only given to those who are allergic to benzathine penicillin. Previously, we used to rely on aspirin, and unfortunately, some protocols and guidelines still recommend aspirin as the first choice, but it's very difficult to use, and children get a lot of side effects. And as we did in Mahima's case, we use an NSAIDs. The most commonly used one is Brufen or ibuprofen at 10 milligrams 3 times a day. It's much easier to use than aspirin, and especially if you're dealing with this child as an outpatient, then I would stick to using ibuprofen or another NSAID that you're familiar with. Steroids should only be used when there is carditis with heart failure. We should not be using steroids to treat rheumatic fever, and even if they have evidence of rheumatic heart disease, without heart failure, there is no need to start prednisolone. But if you do, then you need to start at least 1 to 2 milligrams per kilogram per day. So, do you admit the child primarily because there's a need for bed rest or not? There's very poor evidence that bed rest, when there is no significant carditis, makes any difference to the outcome in rheumatic fever. I think a common sense decision would be, yes, if there is heart failure, when you'd be referring the child anyway. So if you're choosing to manage the child at home and you have a child who's 7 years old, who's not particularly unwell, it's going to be pretty tough to suggest bed rest. But use your common sense. Tell them not to give strenuous activity. Without heart failure and significant carditis, bed rest, in my view, is not essential, and it makes it difficult, particularly for a family, to manage that at home. Now, many of you as family physicians are going to diagnose rheumatic fever without it being found in the acute stage. You'll be doing school health screening, or you may be just listening to a child's heart. And I think it's a good chance when a child comes with any problem to screen for rheumatic heart disease by listening to the heart carefully. These children are often diagnosed because they have a heart murmur. from previous acute rheumatic fever, then I think all of you will refer these children for echocardiograms, because a clinical diagnosis of rheumatic fever in the past resulting in heart valve disease is not reliable. There are many other conditions that can cause mitral valve disease, even though mitral stenosis is almost always caused by rheumatic fever. Mitral regurgitation could have other causes like mitral valve prolapse. So you should not diagnose rheumatic heart disease in an asymptomatic child found on screening to have a heart murmur without an echocardiogram. The prevention of recurrent episodes of streptococcal infection, as Dr. ALEENA commented, is obviously very important. And because every recurrent infection, even if the child had no rheumatic heart disease at the start, will lead to heart valve damage. So the prevention is still based on benzathine penicillin. It is by far the best drug. It's more effective than any oral option that's available. And it should be given at adequate doses every 28 days. There's no need to give it every 21 days unless the person had a relapse of rheumatic fever when on a 28-day prophylaxis. I know there are some specialists who are recommending 21 days, but it should be reserved for people who relapse when on a 28-day schedule, or occasionally when they have very severe cardiac disease. I think reducing the interval puts a significant burden unnecessarily on primary health services, because we are the ones who are going to be there implementing these preventive programs. So let's look at the risk of benzathine penicillin. Allergy is very rare. It may occur in about 3%, 1 to 3% of people. True allergy is uncommon. And severe allergy occurs in 1 in 5,000 injections. So it is rare. Much more common is a vasovagal episode or a simple faint due to the pain from the injection itself. Of course, if you're giving benzathine penicillin, you should have a protocol for penicillin anaphylaxis, and that protocol should be practiced at least once into every 2 months with your whole team, so that everyone is familiar when this does happen, though it's very rare. However, in our situation as in family medicine in India, there are going to be children who have severe cardiac disease, who have not had the benefit of having access to heart valve replacement. So there are going to be children with significant heart failure or on the border who are not very well controlled. In that situation, if the child has a vasovagal episode, there will be a high chance of arrhythmias, which are going to be difficult to resuscitate. So in many protocols, they say that if the child has severe cardiac disease, which has been uncorrected for whatever reason, then oral penicillin is the best option, and penicillin injections, benzathine penicillin injections, should not be given. So if they're only in the situation of uncontrolled heart failure or severe disease where cardiac valve replacement for whatever reason has not been done, it may not be a good idea to give benzathine penicillin. Unfortunately, those situations do occur in India quite often. The second line therapies are phenoxymethyl penicillin, which unfortunately is very difficult to get. And what we often have access to is penicillin G, or Pentids, which is commonly the used trade name. It is completely useless because it has hardly any bioavailability. Only 20% of Pentids or penicillin G is absorbed, and you might as well give the child sweets instead to prevent rheumatic fever. So if there's an allergy to penicillin, you can use erythromycin, but as I said, 30% of streptococci are resistant to macrolides. So Dr. ALEENA mentioned some of the aspects of getting compliance. Now, this is again something where family physicians are crucial, especially when children live in inaccessible places. So what are the things that we can do for compliance? One of the most important things, as Dr. ALEENA said, is to give information to the child and parents in a culturally appropriate way. I was listening to one of our health workers telling a child why they need to have these unpleasant injections. And he was saying that there is this nasty germ that's hovering around all around you. And it wants to get into your throat and it wants to affect your heart valves. And this nasty germ doesn't like these benzathine penicillin injections. And therefore, you need to give it. So culturally appropriate ways. And the children, they may be very young, but you treat them as adults and explain to them in a way that they understand, and the parents too. And this is the most crucial aspect of ensuring compliance. What are the other ways of giving compliance? Benzathine penicillin injections are very painful, and there are ways in which you can make the pain less in primary care. One of them is to use distraction, give the child a phone to play with, looking at their favorite cartoons, or suck a sweet even, or give a sugar lump to distract them. There is no need for a test dose. I know the Ministry of Health and Family Welfare guidelines still recommend test doses, but the World Health Organization 20 years ago showed that the test dose is quite useless. Even if you have a reaction to a test dose, you can still have no penicillin allergy. And even if the test dose is negative, they can still have anaphylaxis. There's no need to poke them twice and cause unnecessary difficulties with compliance. And when children come for penicillin injections to your clinic, don't delay them in the clinic. Give them a priority. Don't keep them waiting. And there's no need to see a doctor each visit. The subcutaneous injection of penicillin, or SCIP, is a new idea that is being developed, and it's already been accepted in countries like New Zealand. This is a method where you give 3 times the volume of benzathine penicillin subcutaneously, and that makes it necessary to give that only once in 3 months. The studies have shown that subcutaneous infusions of penicillin, even though the volumes can be large, lead to much less pain. And remember, you can also use 0.5 to 1 ml of 1% or 2% lignocaine with the benzathine penicillin. They're compatible, and that significantly reduces pain if pain is a problem. And Dr. ALEENA mentioned about rewards. Keep some of these ready. What we say is that we make a pact. You come for 6 months, you get a reward. And that's something a family physician, it's often one of the fun things you can do. Or you can agree with the parents that they go for Deepavali and get a clothes for Deepavali. Every time the child completes 6 courses, they get something that they like. So this is a favorite among children to get compliance. And Dr. ALEENA mentioned about the recall system. We have both acute and chronic recall systems. We have the name of the child, and every month when the child's due for the penicillin injection, a phone call is made and the child's parents are informed the penicillin injection is due, and also during the village visits. So how long do you give these penicillin injections? As family physicians, we're not going to sometimes get all the Jones criteria present. Sometimes you see a child with the monoarthritis and fever, but they came late and the other tests were not very useful. So there is a role for diagnosing a child as having possible rheumatic fever. If that's the case, the current recommendation in many countries is to give them 1 year of benzathine penicillin and stop it if after 1 year the echocardiogram is normal. The other things I think you all know that it's in the Ministry of Health and Family Welfare guidelines, it's 18 years or 5 years from the last episode if there's no carditis. And it's 10 years if there was carditis. The Ministry of Health and Family Welfare says 25 years. What do you do if a person on penicillin prophylaxis gets sore throat, or even if they've defaulted and they get sore throat? You've got to educate the person that any sore throat in a child who's had rheumatic fever requires benzathine penicillin. In a child who's had rheumatic fever, the CENTO criteria do not apply, and they need to have benzathine penicillin, even if they are on prophylaxis already. The streptococcus does not get resistance to benzathine penicillin. How often do you follow up? Usually every 12 months, initially after cardiac surgery, and then every 2 years. If they have severe valve disease, then it should be done every 6 monthly with the cardiologist. In stable rheumatic heart disease, I don't feel that it's necessary always to see the cardiologist every year. And as a family physician, you should be able to review them every year and refer them every 2 yearly. Even if a prophylaxis was stopped and the child had mild rheumatic carditis, they will still need regular echoes every 2 years, because mild mitral stenosis can easily progress to mitral stenosis over many years, even without further relapses in rheumatic fever. So if you're finding it difficult and you're in a difficult and remote area where echocardiograms are difficult to access, and some of our patients do live in that situation, what I do is that if there is mitral valve disease causes symptoms very early in the course of its progression. So in mitral valve disease, you can wait for symptoms to occur before you need to do an echocardiogram. Now, this is not in the guideline. Again, as I said, as family physicians, we need to look at guidelines and adapt them when the situations are difficult and contextual factors make it difficult. Because in mitral valve disease, symptoms occur early before significant cardiac damage has occurred. So I would often delay echocardiograms in mitral valve disease in asymptomatic people. The same does not apply in aortic valve disease. There's aortic stenosis or regurgitation. You cannot wait for symptoms to occur because they occur late in the course of the disease, when it's too late sometimes to intervene. As a family physician, you've got to look at the person as a whole. I spend a lot of time educating my children with rheumatic heart disease to please attend school and do your best to encourage schooling, because these are children who, when they grow up as adults, may not be able to do physical and manual work. So in them, more than others, perhaps, it's more important they complete their schooling. And the less interference we do with their schooling, the more useful it is for them. So often give a letter to the teacher saying that they need to come for injections once a month to allow that to happen, because some teachers get annoyed at the time the child spends away trying to get the penicillin prophylaxis. But I also encourage the child to continue the schooling. Don't forget anemia, as Dr. ALEENA said, because anemia is common, and in a person who's got borderline heart failure or rheumatic heart disease, hemoglobin of 8 grams, which is so common amongst the children here, is not acceptable. And often the most important drug that they take is oral iron. Dental hygiene is also important for reasons to prevent bacterial endocarditis. So when you review the child, look at their teeth. Make sure you look at it every 6 months. And the best way to prevent dental disease is to encourage children to brush their teeth before going to sleep. Now, regarding bacterial prophylaxis, if a child has rheumatic heart disease, the criteria for giving SBE prophylaxis when they have procedures done has changed, because rheumatic heart disease with prosthetic valves is a major risk factor for SBE, and then they should have SBE prophylaxis. And obviously, if they've had a history of SBE before, bacterial endocarditis, then they need antibiotic prophylaxis. But in our situation, our children with dental disease have often got severe dental disease. And that some children with rheumatic heart disease who haven't had cardiac surgery have got significant heart valve disease. The guidelines that were developed by rich nations, which said that you don't need antibiotic prophylaxis in rheumatic heart disease itself without prosthetic valves. I feel that's not necessarily the case. If the dental procedure is for a major dental infection, then antibiotic prophylaxis should be given, and the best drug is still amoxicillin 2 grams before the procedure is done, and that's something that as family physicians we need to recommend. So even if they've had penicillin prophylaxis, the drug of choice still is amoxicillin. So I'm trying to say that as family physicians, we are the key to preventing severe rheumatic carditis, and we need to be proud of that in making a difference in India. So you need to know the guidelines, but sometimes you need to adjust them and adapt them to individual and contextual factors. So thank you very much for that. If there are any questions, we can try and answer them.
Sir, thank you so much, sir, Dr. Ramasamy, sir. So very overwhelmed for your class. We had a excellent class today. Actually, I listened like a student to you. So like we actually read from the books, the practical things which we have to look into when you are residing in primary health center, where the sources are very limited, but you make sure that you screen those patients. Like I've heard a lot about rheumatic fever in various talks, but this was an excellent talk from you, sir, because whatever we read, it is all told in the conferences and places. But today you have highlighted that without any, with no proper resources, you are able to treat and keep a follow-up of all these patients. I'm really happy. As a student, I heard your class. It was really, really very good, sir. I learned so much from you today, sir. Thank you so much for your speech.
Thank you.
Any other questions, Shweta? Anybody wants to ask any questions to sir? I'm not able to hear you. We can't hear you, Shweta.
Hello.
Can hear you.
Hello. Hello. Hi, Raj. I'm Dr. Nitin.
Hi.
I'm from AIMS, Jodhpur. I'm doing my third year of residency here. And you might better know me as one of the travel fellow who never came to you. So what I wanted to ask you is, like, we were able to diagnose and manage acute rheumatic fever and thereby prevent rheumatic heart disease. But it is also a streptococcal throat infection miss. So how can we like decentralize the antibiotic thing into the hand of health workers so that people with access in the villages can get their antibiotic over there itself? Or what all can we do in the community so that we don't miss a streptococcal throat infection, especially when we're working in rural areas?
Yeah, that's a very good question. I think, as I said, our health workers, when they are quite capable of looking at the center criteria and managing them, because the center criteria are quite straightforward, and they're taught the four criteria for sore throats being suggestive of streptococcus and due to streptococcal infection. So I think if you have two or more points that suggest streptococcal infection, they should be given an antibiotic. Obviously, if they're going to the field, then giving benzathine penicillin is not a feasible anymore because of the very small risk of allergy, but that being alone as the health worker going to a field visit, that's really not possible. So if that's the case, they will try their best to get the patient to come to a place where the benzathine penicillin can be given. And as primary care doctors, we need to do peripheral visits, peripheral clinics where we can give benzathine penicillin. In Mahima's case, in her own village, we are capable of giving the penicillin prophylaxis. Now, if they can't do that, then I think azithromycin is a poor second choice, or amoxicillin. Amoxicillin is a drug that can probably be better than than azithromycin because of the lack of resistance to penicillin. It is a broad spectrum penicillin, so that the problem of antibiotic resistance is bigger in giving amoxicillin. But giving amoxicillin at 40 milligrams per kg twice daily is, I think, the best alternative for health workers to use. Otherwise, our health workers will phone us up. Mobile connection is poor in some villages, but it's quite good in others, and they'll ring us and ask for advice. Did I answer your question?
Yes, sir, that answered the question. Thank you.
Thank you, sir, for the wonderful presentation. Does anyone have any other questions? Please, you can raise your hand or you can unmute yourself and ask now. If you have any suggestions, anything which you want to add, also you can say. Dr. Karthi has mentioned, we now frequently observe adult patients presenting with heart failure because they discontinued their prenatal prophylaxis after an initial period because of being asymptomatic. So consistent long-term follow-up with the dedicated team is the key. So this is about regarding adult prophylaxis of rheumatic in rheumatic heart disease patients, secondary prophylaxis. So do you want to add something to what they've said?
Yeah, adult acute rheumatic fever in adulthood is less common. As I mentioned at the start, people living in crowded conditions are the ones who are going to get relapses of streptococcal throat infections. So if a person who had carditis is on penicillin prophylaxis, their situation has changed. They stopped going to school. They moved away. They're working. They're living in an uncrowded house. Then the chances of them getting relapses is less. And in that situation, I often don't go after them as much as if they were still at risk. So if the prophylaxis in adults who are at risk is no different to what we've already said in children. And it needs to be carried on for at least 5 years after the last episode and at least till the age of 40. Especially if they're living in crowded conditions or there are other kids around in the home who are going to spread streptococcal infection to them.
I think, sir, with the current urban population, there is more overcrowding than it is in the rural areas, in adults and in all the population as compared to the rural areas in different ways. So I think it has to be taken into consideration and also regarding the adult prophylaxis, I just want.
Yes, sure. I think people living in slums are at very high risk of relapse of streptococcal infection, and then may need to be even given for lifelong. So the age of 40 is just a suggestion. And as I said, as family physicians, we need to look at the contextual and individual factors and modify treatment. If they're living in slums, they've got serious heart disease, then the penicillin prophylaxis should be for life. So thank you for making that point.
So I hope, is there anyone else who wants to ask any question? Can ask now. Otherwise, we'll wind up the session.
Hi, sir. This is Aravind. I just wanted to mention one point regarding our colleagues, people, especially who are working in secondary care hospitals, and even the guidelines doesn't put rheumatic fever as a differential to polyarthritis, but actually in practicality it is very common. So I think we all need to be aware of rheumatic fever when, especially when you are evaluating arthritis in a pediatric age group.
Yeah, thank you for that point. And polyarthritis or monoarthritis is it's the commonest way that rheumatic fever presents. And if you're in the periphery, then you may just have that history of fever, and that's all you have at that time to go on. And all the other tools like ESR and ASOTs may not be, the ASOT doesn't fit as a minor criteria anyway, and the ECG for looking at the PR interval may not be available. So this is where they suggest that there should be another situation called rheumatic fever, possible rheumatic fever, but not proven. And in that situation, guidelines which accept that criteria say give penicillin prophylaxis for 12 months at least, and try and get the other investigations done, especially an echocardiogram when you can, and only stop penicillin prophylaxis once you've had the echocardiogram.
So one more thing which I wanted to, we already talked about that, just want to make it clear during the session. So acute rheumatic fever, with clinical carditis, PR prolongation, we have a acute criteria, but there is also another entity called the subacute carditis. Even guidelines say that they needs to be taken up as carditis. So the main reason for people to do echo early is what if we miss the subclinical carditis. So if echo is not going to be very accessible immediately, is there any way to manage that? Or that is acute rheumatic fever with no baseline tachycardia, no PR prolongation. But if you're what do the subclinical carditis? That is the way that even that guidelines goes. So just wanted to.
Yeah, thanks for asking that. I think the subclinical carditis is an important thing, and that's why in the guidelines now recommend an echocardiogram during the acute stage. The problem with doing that is that you then need to repeat an echo later to see how bad the cardiac valve, how permanent the valve damage is, because the acute carditis often resolves, and what looked like significant mitral regurgitation or aortic regurgitation, 3 months later that murmur is much less and gone. So to detect subclinical carditis, ideally, according to the guidelines, you need to do an echocardiogram during the acute phase of rheumatic fever. But to see how significant the permanent damage is, you need to do another echocardiogram once the acute inflammatory phase is over. So in my view, if there is no cardiac failure, don't worry about an echo till 2 or 3 months later. Then you have something that tells you if there was subclinical carditis, and it tells you how significant the ongoing damage is. But this is not in the guidelines. The guidelines say you should do an echocardiogram, but they are guidelines written in tertiary hospitals by specialists. And we as family physicians have to find out a practical way. So in suggesting alterations to our approach, I'm not questioning the guidelines because they're for ideal situations. We work in non-ideal situations. And if a child doesn't have heart failure, then I would wait to do an echocardiogram. Because wait for the acute inflammatory situation to finish and then do the echocardiogram.
Yes, thank you for answering that. So we are almost reached the end of session. If there's any questions that we want to address, we can address that now. We'll just give a minute if anyone wants to ask any question, and then we'll wind up the session. Is that okay? So I think there's no other further doubts. If you want to ask anything to sir or to ma'am or to anyone, you can ask in the Spice Root group. TN Spice Root group is for that purpose, which I will provide the necessary reply or whatever you need. So thank you, ALEENA, for a wonderful case presentation. You have put effort in making the PPT and making all the corrections and everything. Thank you, ALEENA, and thank you, sir. You've, I think, you've done most of the presentations today, as how our classes also go. So, thank you for the presentation, and I hope the postgraduates would have understood what family medicine is and how we can make a difference as working as a family physician in this country, and how this residency is going to help them pursue that. So I really hope that they've gotten their identity right. They don't. And thank you, Pranita ma'am, for being a great moderator and also organizing and also being a part of the team. And so I think we can end the session. So thank you, postgraduates. Thank you for attending it. So so today we'll wind up and let's catch up next month with another session. So thank you.
Thank you.
Thank you, Shweta. Thank you, Spice Root chapter, Tamil Nadu chapter. Thank you very much, sir. Thank you, Dr. ALEENA. And next month, I think Kerala chapter, state chapter will be presenting the case. Thank you very much. Thank you, everyone.
Thank you all for giving such a wonderful opportunity to present a case in this Spice Route. And also thank you so much, sir, for guiding us and giving such a wonderful presentation and clear understanding about the condition. Thank you so much, everyone.
Thank you.
Thank you. Bye, everyone. Good night.